Wonderful. So to tell you a little bit more about CCMRH, CCMRH is a program of the Kenneth Searle Valley Foundation based in Trinidad and Tobago, which provides mentorship and community service opportunities rooted in the mantra of progress through service. CCMRH is a regional network that seeks to provide resources and support around maternal and reproductive health across the Caribbean region. Through CCMRH, we seek to meet people where they are by providing resources and connections and a space to come together like this and share in community. We're very happy that all of you could join us today. And if you'd like to learn more about CCMRH or join the coalition, you can visit our website, www.ccmrh.org, or our socials at Caribbean CMRH. Tonight, we are joined by Dr. Rashida Daisley from Barbados Association of Endometriosis and PCOS, and Yashi Carrington from Mind of Yash, who will facilitate our group discussion today.
Today's community conversation will be about PCOS as it relates to sexual and reproductive health. We will start with an informational presentation from Dr. Daisley, and then we will open up the conversation for you all to ask questions, comments, and share your knowledge and experiences with PCOS, if any. We want this to be an informal discussion where you can ask questions, give comments wherever you like. And after the presentation, if you want to jump in and use the raised hand function on Zoom, you can do so. We wanted to note that we would be recording Dr. Daisley's presentation only, and then we will stop the recording before the community conversation section. The only recording we will share will be of Dr. Daisley's presentation, so no videos of attendees will be shared. So during the community conversation, we would love to see everybody, but if you're more comfortable keeping your camera off, please feel free. Okay, so I guess we can go ahead and just start. First, we will introduce Dr. Daisley. Dr. Daisley, Rashida Daisley, is a general practitioner with a burgeoning interest in public health advocacy and policy development. She is the current medical director of the Barbados Family Planning Association. Stemming from her personal and professional experience, Dr. Daisley is passionate about sexual and reproductive rights advocacy. And living with PCOS herself, she is passionate about helping her fellow sisters manage the condition, and her role as the president of the Barbados Association of Endometriosis and PCOS is a testament to her devotion to the field. So I guess, Dr. Daisley, you can start sharing your screen, and thank you for joining us today, and we really look forward to hearing the information that you have to share.
So thank you so much for having me, first of all, and thank you so much for everyone who's joined us today. I know on a Saturday afternoon, it's hard to pull yourself away from chores and so on, but we really appreciate you being here. So I'm just going to go ahead and share my screen, and then we'll just get started with a very quick presentation about PCOS and its link to fertility. I'm just going to try to close it there. Perfect. All righty. So my presentation is entitled PCOS Beyond the Diagnosis and How We Can Understand How to Thrive with PCOS. So this is just an outline of what we'll be covering today. So we're not going to go too in depth in the presentation, as I really want to ensure that the bulk of the conversation comes from the audience, where we're able to kind of gain some dialogue from each other about how we can best manage PCOS. But we're going to look at what PCOS is, what are the symptoms, how it's diagnosed, look at PCOS and fertility, and how we can best manage PCOS on our own. So first of all, I'm going to tell you a little bit about us, BAPE. I'm representing the Barbados Association of Endometriosis and PCOS. We're a registered charity here in Barbados, and we seek to educate citizens as well as advocate for those who are afflicted with endometriosis and polycystic ovarian syndrome. So we do this through similar outreaches such as this in terms of presentations. We've also held medical conferences. We held walks, where you can see here our Endo March walk. I think this was in 2017. But I'm very happy to be here representing the organization. And now a little bit about me. So I know Khalida would have shared my biography, but one point that makes me an interesting perspective here is that I do have a dual perspective, both as a physician who manages our patients in the realm of sexual and reproductive health, often persons with PCOS, but I also am a sister myself. So I was diagnosed with PCOS in medical school. So that was about 10 years ago now. And at that point, I hadn't had a period, I would say, for maybe like 3 months. And I was a little bit concerned. So I would have gone to one of the gynecologists that I was working with in medical school. They would have done an ultrasound and saw the cysts. And based on that, they were able to diagnose me with PCOS. But beyond that, I wasn't given much other information. I was just advised to go on the birth control pill to kind of ensure, at that point, we termed it regulating our period. But basically, I know now that that's just ensuring that I have a bleed every month. It wasn't really until I finished medical school and I did my own reading and research that I understood the pathophysiology or what is happening behind the scenes in PCOS, and that really lifestyle changes are a crucial point of it. So I was able to lose a significant amount of weight on my own and keep it off. I mean, before COVID, a little bit has come back on, but I have been able to manage it on my own, so much so that my periods have become regular and I do not need to use the birth control pill to ensure that I have a bleed every month. But what exactly is polycystic ovarian syndrome? It's a very complex condition, and it does have psychological, reproductive, and metabolic manifestation, and it impacts health across the lifespan. So I know often when we're talking about PCOS, we limit it to ladies of reproductive age between the ages of 16 to 45. But even in that postmenopausal area, our life course, there are still some implications in terms of PCOS, and we're going to get into a little bit more about that in terms of its association with risk with insulin resistance, development of diabetes, hypertension, and even metabolic syndrome, which, as we can see, have implications beyond reproductive age. So when I talk about PCOS, I like to break it down into these 3 aspects. So obviously it is a reproductive disorder. That's why we're here today, the CCMRH, kind of discussing it. And that kind of manifests in the terms of its irregular periods and its impact on fertility through anovulation. So anovulation just means that these ladies are not actually ovulating. So we're going to get into that a little bit more, and that how it impacts fertility. But it's also a metabolic disorder. And this is one of the aspects that we really need to focus on if we're trying to manage or really instill in persons that it is crucial to have some lifestyle interventions in managing PCOS. So what happens in PCOS is that there are elevated levels of insulin in the blood. And insulin is a hormone that we often hear about it when we're talking about diabetes, when diabetics have to go and give themselves insulin shots to ensure that their blood sugars stay regular. But within our bodies, we also produce insulin naturally. And what happens in PCOS is that the body's insulin, the body's not really responding to insulin as it should. I like to liken it to, for example, if you wake up on Monday morning and you have to go to work, you're really sluggish, you're not doing much, you might need a lot more persons to do a particular task. And that's what happens. So the body becomes resistant to the insulin, and therefore you need a lot more insulin. And that hyperinsulinemia then drives a lot of the other hormonal factors that come into place in terms of the elevated levels of androgens or male hormones. And that also feeds back into increasing things such as obesity and central obesity. And that's why we become concerned about the metabolic complications associated with PCOS. And again, both of what I spoke about before are hormonal disorders, but even more so, it leads to elevated levels of androgens or male hormones. And that's because of the high levels of LH or luteinizing hormones. And that also as a result of the insulin that we see. So as we can see, it affects a number of different areas in our life: reproductive, metabolic, even the manifestation in terms of male hormones. So it is not a simple condition. So I thought it would be important to kind of touch on the normal menstrual cycle and then what really happens in PCOS. So if we can just cast our minds back to, I guess I'm talking to an American audience partly. So high school, or for us who live in the Caribbean, secondary school, biology, where we were learning about the menstrual cycle. So it's divided into different halves. So in the first half of the menstrual cycle, there's some hormones, I should probably say, that kind of orchestrate the menstrual cycle. So these hormones would include FSH, or follicular stimulated hormones, luteinizing hormone, and obviously our progesterone and estrogen. So these are secreted both by the brain as well as in the ovaries as well. So in the first half of the cycle, what's happening is that the body is selecting an egg that is going to mature basically in preparation for possible fertilization by a sperm and subsequent implantation. So that is done by the follicular stimulating hormone, or FSH. And then it develops a follicle that contains an egg. And when the egg is therefore ruptured or released from the ovary, then that's what we call ovulation. And that's caused by what we call the mid-cycle surge in the luteinizing hormone. And that's what really causes the egg to be released from the body. And that normally happens about 36 to 48 hours after that surge in the luteinizing hormone. However, what happens in ladies with PCOS is that we're not able to actually cause this actual ovulation. And the body is not able to do that because the levels of LH actually remain at a steady higher level. And we're not actually seeing that surge in the luteinizing hormone. It kind of just remains at that elevated level. And what we're seeing on the ultrasound when we see the cysts are basically the failed attempts at ovulation. Those little cysts represent failed attempts at ovulation. And the cysts tend to be small, between 4 to 9 millimeters. However, in some patients, they can rupture and cause persons to have significant amount of pain. And one thing I do like to highlight is that although ovulation may not happen with every cycle, ladies with PCOS can still ovulate sporadically. So we still have to talk about contraception as well. So PCOS is actually it's one of the most common endocrinopathies that we see in women of reproductive age. In some populations, it can reach up to 12%, but in average populations, between 6 to 8% of women of reproductive age. But as I said earlier, it's a lot more than just being confined to that reproductive age. It has lifelong implications on health, far beyond the childbearing age. And this, again, likens to the association of PCOS with insulin resistance and obesity. And that can also increase the risk of things like type 2 diabetes, hypertension, cardiovascular disease, some cancers, and metabolic syndrome. And these can all lead to increased morbidity and mortality, even in the postmenopausal range. How exactly do we diagnose PCOS? So most commonly in the Caribbean, we would use, and in the UK, I also think we use the Rotterdam criteria. And we need 2 out of 3 of the following criteria. Clinical features of hyperandrogenism, and this can be manifested as what we call hirsutism, which is increased hair growth in the male pattern, for example, the upper lip, the chin, the chest, the back, and the abdomen as well. Other forms of manifestation of hyperandrogenism would include things such as acne as well. You might also notice acne, as I said, hirsutism as well. Menstrual irregularities, so this tends to be in the form of amenorrhea. Persons may notice that they're skipping months. They may also notice sometimes that when the period comes, it might be a little longer. Persons with PCOS also may have very late periods as well, but the menstrual irregularity is a hallmark. And the last one is obviously polycystic ovaries on ultrasound as well. So we need 2 out of 3 of these criteria to diagnose a person with PCOS. And it's lesser known, but there are actually different types, or what we call in the medical field phenotypes of polycystic ovarian syndrome. And we classify those into type A, B, and C, depending on which category of the Rotterdam criteria is achieved. Type A is a classic type that has all 3. So those persons that have androgen excess, they would also have ovulatory dysfunction, or basically the irregular periods, and the polycystic ovaries on ultrasound. Type B are persons who would have symptoms of androgen excess, or it can also be clinically or biochemically confirmed androgen excess, in addition to the ovulatory dysfunction or irregular periods. Type C also have the androgen excess and just the polycystic ovarian ovaries on ultrasound. And type D is just the ovarian dysfunction as well as the polycystic ovaries. In my practice, I think that type D is probably what we would see most commonly in terms of the irregular periods and the cysts on the ovaries. It's also very important for us to highlight that just having polycystic ovaries on the ultrasound does not mean that you have polycystic ovarian syndrome. For example, if a lady has polycystic ovaries on an ultrasound and they're continuing to have their periods, we're doing testing that shows that they're ovulating there's no biochemical evidence of androgen excess, we can't say that that patient has polycystic ovarian syndrome, but they do have polycystic ovaries. So there's a distinction that we have to highlight there. I thought it was also important for us to kind of highlight what exactly we mean by an irregular period. Because, for example, in the first years after what we call menarche, which is what are basically as ladies our first period, the first year irregular periods are actually normal. But beyond that, for example, after the year of menarche, if a patient is having a period that's less than 21 days, a cycle, sorry, that's less than 21 days or more than 35 days, or if they're having less than 8 cycles per year, that can be defined as an irregular period. And if there's at least 1 year post-menarche and they're having 90 days for any one cycle, that can also be constituted as an irregular period as well. So based on this, we can see that it's a little bit difficult to really diagnose polycystic ovarian syndrome in adolescents who, for example, who have just gone through their menarche, because we can't really say for sure whether that is a true irregular period or whether that's just part of the pubertal transition. So let's talk a little bit more about polycystic ovarian syndrome and fertility. As ladies, one of the hallmarks of something that we want to achieve is obviously to have a child. The majority of ladies, not everyone wants that, of course. But infertility, or what I prefer to term subfertility, is present in about 70% of women with PCOS, and it causes 70%, of ladies with ovulatory infertility is caused with PCOS, and it makes it the most common cause of ovulatory dysfunction in women. So it's a very important cause of infertility in women, and it's one that is actually able to be treated easily. So when we're looking at how PCOS causes subfertility, there are many different areas in which it does that. Obviously, the anovulation, where ladies do not ovulate or do so sporadically, but it also affects the oocyte or egg quality. So as we would have looked at earlier, we mentioned that the levels of hormones that normally would orchestrate the menstrual cycle are significantly changed in PCOS, and the folliculogenesis is often disrupted, and that leads to suboptimal oocyte competence, and therefore can affect the quality of the egg as well. Additionally, the endometrial receptivity is also changed as a result of these changes in the hormones. And in the absence of ovulation, the progesterone effects on the endometrium are lacking, and therefore severely decreased. So progesterone is a hormone that causes the thickening of the endometrial lining. So that's just before our periods, our progesterone levels tend to be very high. The body is ready and waiting to have an egg implanted. So it wants to make sure that endometrial lining is nice and thick and ready to receive an egg. But what happens in PCOS, because there's no ovulation that normally would stimulate the first increase in progesterone, the progesterone levels tend to be lower, and therefore the endometrial lining tends to be a lot less thick. We also would have discussed the hyperinsulinemia due to the insulin resistance, and that has implication in terms of the increased risk of things like gestational diabetes. So for women who are successful in conceiving, that hyperinsulinemia and increased risk for diabetes translates also into pregnancy. And the risks associated with gestational diabetes are separate and apart from PCOS, but they do have implications for the mortality and morbidity both for the mother as well. And there's also an increased risk of hypertension, particularly for those ladies with PCOS who tend to carry excess weight. So how exactly can we improve fertility in PCOS? So there are different tools that we can use. Weight loss or lifestyle modifications is the first line. So we would often recommend that ladies lose weight. At least about 10 kilograms can do a great advantage to our fertility as well as our risk in terms of developing things like gestational diabetes and hypertension. We can also use insulin sensitizers, for example, metformin, and these basically would assist with reducing the levels of hyperinsulinemia and improving the sensitivity on the insulin, and then that can actually stimulate ovulation as well. There are some medications that are specifically dedicated to inducing ovulation. So the most common ones would be Clomid or clomiphene citrate, as well as letrozole. And there's laparoscopic ovarian drilling that's not practiced as much now, and assisted reproduction, or this can be basically fertility treatment or implantation. So when we look at PCOS, one of the aspects that we would often talk about is obesity and how it relates to PCOS. And this has implications as well for the fertility. Obese women are 3 times more likely to have infertility when compared to normal women. And this is even without having PCOS. And 80% of women with PCOS do have increased BMI. But I would like to highlight here that even those ladies with what we call lean PCOS, there are some implications in terms of insulin resistance as well. So it's not that they are kind of exempt from that aspect. And the infertility rate actually increases by 4 times per BMI unit. And that's quite a significant amount. Central obesity decreases conception by up to 30% per cycle, and that for each increase in waist to hip ratio. So that's basically the ratio of your waist circumference to your hip circumference. So ways that we can correcting obesity can actually help to improve weight loss, to improve fertility, So 5 to 10% of our weight, if we're able to lose it, can improve insulin resistant ovulation rate as well as pregnancy rate. And weight reduction also reduces the risk of gestational diabetes and even hypertension in pregnancy. However, it isn't recommended that we wait until a person achieves an ideal BMI to initiate or start conception. The reason for that, especially for ladies who are advancing in age, is that obviously there's a short window there. So we want to encourage women to start the ovulation or to start attempting pregnancy even before they have reached their ideal weight. Okay, so I'm going to pause here now. So that's just a brief overview about PCOS and how it kind of relates to fertility. And I really hope that in the discussion that we can really dive a little bit deeper into the subtle nuances and really get into the meat of the matter.
Thank you so much, Dr. Daisley, for that presentation. I think, we definitely all learned a lot from what you had to say. And we do actually have some questions as well for you that we received from registrants. So I'd love to ask you some of those. Some of them you've already answered. One of the questions was around how to boost fertility and ovulation while having PCOS, and you did mention that already. But I had a question based on what you mentioned around using medications, for example, like Clomid. And I was just wondering, are those very accessible across the region, or is there a significant cost to those? And then how would you go about accessing them if you were interested in something like that?
So they are readily accessible, and I can only speak for Barbados. So definitely both Clomid and letrozole. So we have to first obviously look at if a lady is ovulating, because they might not need to have these medications. So we do that first by trying to estimate the day 21 if a lady has a regular cycle progesterone levels. But it tends to be a little bit more difficult in ladies with PCOS because obviously they don't tend to not have irregular cycles. So in that instance, then we can still just look at the hormonal levels and see if they are a candidate for these particular medications, but they are readily available and accessible. I'm not entirely sure of the cost, however.
Okay, great. Thank you. That's really helpful. And then another question was around inflammation in the body. So if there are any natural ingredients that can reduce inflammation in the body for someone who has PCOS, for example.
Yes. So PCOS does tend to carry a low-grade inflammatory response. And additionally, for those ladies who are obese with PCOS, the obesity also does have a pro-inflammatory state. So we can even see clinically or biochemically, if we check, for example, their C-reactive protein or erythrocyte sedimentation rate, those are both blood tests basically that we can use to kind of estimate the levels of inflammation within the body. We see that those tend to be elevated in these ladies. In terms of how we can kind of reduce them, so it's a little bit difficult to say. There are obviously weight loss will definitely help with that. There are some alternative medicine methods that persons use, for example, turmeric, either tablets or turmeric in raw turmeric tends to help with inflammation. But things, for example, such as inositol, which is a supplement that's used in the management of PCOS, that also tends to help to reduce inflammatory levels. Also, N-acetylcysteine, which is another supplement that is used both in the management of PCOS and obesity, can also help to reduce the levels of inflammation within the body.
Perfect. Thank you so much. And then along a similar vein for, anyone, all ladies, different sizes, things like that, who are maybe facing PCOS, are there any, tips that you would have around diet that could help, like maybe certain foods to eat? I know we talked a little bit about tablets around inflammation and turmeric and things, but around the diet more generally, is there anything that you would recommend or that you can do to help manage maybe PCOS symptoms?
Sure. So when we're looking at the diet in terms of PCOS, we're looking at ways that we can help to reduce that hyperinsulinemia. And insulin, obviously, as I mentioned earlier, responds to sugar. So we're looking at reducing the amounts of very simple sugars within the body. Obviously, it's very difficult to remove an entire food group, and that cannot be recommended. For example, like removing carbohydrates altogether in your food in your life can be very difficult. But when we're talking about carbohydrates, they're simple as well as complex carbohydrates. So simple carbohydrates are broken down very easily within the body, and they go directly into the bloodstream very quickly, and they cause a sudden surge in your insulin levels, and that can cause the ladies to feel very sluggish and so on. For us, when I'm not sure if in America, but in the Caribbean, sorry, we would have this thing called, I will term it ethnic post-conception syndrome, where after you eat, you want to go sleep. But that's basically what's triggering that. When we use foods, our carbohydrates are a bit more complex, that the body takes a lot longer to kind of break down and digest, and they're secreted into the bloodstream a lot easier. They tend to not cause that significant spike in the insulin, and therefore you tend not to have that sluggish feeling afterwards. And it also helps with managing the insulin levels in ladies with PCOS, and also can help in terms of a little bit of weight loss as well. There have been some more so anecdotal evidence to suggest that removing dairy from the diet also helps with that. But I don't think there's much actual scientific evidence in terms of removing dairy to assist with the management of PCOS per se. I do find that diets that have a reduced amount of red meat also tends to reduce the amount of inflammation, and also helps ladies to improve how they're feeling. Other supplements such as omega fish oil as well can also be quite helpful.
Okay, great, thanks. And then just a quick follow-up question to that. Do you have any examples of complex carbohydrates that folks should be integrating or may want to help with the symptoms?
Sure. So examples of complex carbohydrates would be things like brown rice. For us in the Caribbean, ground provisions, things like sweet potatoes, yams. Yeah, so more like something with more fiber content in it rather than just the white rice that's just broken up very easily. Even things like quinoa as well can be helpful.
Okay, no, that's really great to hear. Thank you so much. And then just around PCOS and contraceptive pills. So you spoke a little bit about PCOS and contraception and talking about, how some ladies with PCOS may still ovulate. So it's important to be thinking about contraception, as you mentioned. One of the questions that we received, and maybe we can talk about contraception more broadly as well, but was around, can taking contraceptive pills with PCOS boost their fertility, or how might that work? So I guess that's kind of two questions.
Right. So no. So the birth control pill, the only recommending in PCOS is basically to ensure that women are having a bleed, because one of the concerns is something called endometrial hyperplasia. So for example, when those ladies are going many months without having a period, sometimes what can happen is that the lining of the womb, the endometrium, can continue to build up, and that's something called endometrial hyperplasia. Some rare circumstances that can lead to things like endometrial cancer, which is one of the cancers that we become concerned about that's associated with PCOS. So ensuring that you have a bleed every month, that's mainly why we're recommending having the birth control pill. In terms of fertility, no, it wouldn't help with fertility because it's basically stopping ovulation as well. So that's basically what the birth control pill does. So it wouldn't assist with fertility.
Perfect. Thank you so much. And is there anything else you may want to share around contraception and PCOS? I'm not sure if this is something that's talked about broadly or something that some ladies may not, know the importance of contraception. If their doctor, for example, may have told them, oh, you're not ovulating. I know some folks may have had that, face that situation. Is there anything we want to speak to more around, the intersection there?
So I find that there are quite a few ladies who become concerned about the birth control pill. I do know lots of ladies they don't really become excited basically to use it. I think one of the reasons for that has to do with the many different complications associated with it, and then obviously the weight gain associated with it as well. But especially for that reason, in terms of endometrial hyperplasia, that's one of the main reasons that we kind of recommend it. In terms of other forms of birth control, sometimes I would recommend, depending on how the patients are presenting, because there are some ladies with PCOS who might actually have pronounced bleeding, which is something that I see sometimes as well. We may recommend, like for example, the Mirena intrauterine device, which is a hormonal intrauterine device, secretes a small amount of progesterone hormone, and that also can help to control dysfunctional uterine bleeding if that's how the female is presenting. But we wouldn't recommend birth control unnecessarily. It's definitely for a reason.
Perfect. Well, thank you so much, Dr. Daisley. That was the last question that we had, but we really appreciate your presentation. We definitely learned a lot from what you had to say, and I think this will help a lot of folks. So thank you so much. And at this point, I'm going to pass to Kalita so we can move on to the community conversation, and I'll stop recording. Thanks.
Okay.
That was so great. Thank you so much, Dr. Daisley, for all of this.